Technology Summit 2021. I would like also to extend my thanks to the chance and the company to give me the opportunity to join this distinguished gathering and an important scientific event. I talk today whether the human arthritis, bridging the gaps and elevating the outcomes. First of all, as all we know, rheumatoid arthritis or other rheumatoid disease. Rheumatoid disease is a chronic inflammatory disease characterized by articular manifestations in the form of the joint swelling, tenderness, and distraction, leading to severe disability as well as extra-articular manifestations leading to premature mortality. Its prevalence about 1% worldwide, and the incidence about 3 in 1,000, and the rate of elimination is 1 in 3. My agenda today will focus on the clinical features of rheumatoid and the classification criteria, followed by the guidelines of management, and then clinical focus before I conclude. The pattern of the disease onset of rheumatoid arthritis may be typical or atypical. The typical pattern of onset, usually in 55% or more of the patient, coming with an insidious onset is bilateral symmetrical polyarthritis of the small joints, which is very common, or may mimic spondyloarthropathy presented by monoarthritis or with arthritis in large joints, or may mimic the polymicrogyria rheumatica with the systemic features in the form of fever, loss and fatigue, with marked elevation of acute physical activity, usually occurs in this old age. Or may present in 15% by an acute onset interval patient with an exclusive polyarthritis of the small and large joints. The atypical pattern of onset usually involves an anatomic rheumatism, which is most common in the atypical form. Usually over time, 30-50% of patients will evolve into rheumatoid, especially with the hand involvement, or maybe present with arthritis rheumatis in the athletic men with a bulky proliferative synovitis and joint deformity, or may present with an extra-articular manifestation, and the most famous one is the interstitial lung disease, and many of our colleagues in the pulmonology departments usually refers to us the patient presented with the high resolution CT chest with ILD, either usual interstitial pneumonia or non-specific interstitial pneumonia, seeking for an underlying cognitive tissue disease, mainly rheumatoid or systemic sclerosis. The extra-articular manifestations usually in the form of pain and swelling in the articular manifestation usually in the form of pain and swelling in the affected joints activated by movement, and in the most common symptoms associated, as all we know, with prolonging status for longer than 1 hour and with different joint involvement. Usually 90% have an LCPs, PIPs, or MTPs or joints involvement, followed by 80% in knees, ankles, and wrists, 60% in shoulders, and 50% in hip, and 50% in presents with the temporomandibular joints, appendicular joints, or sternoclavicular joints. The affection of these joints usually in the hand joint leading into various deformities with radial deviation of the wrist, palmar subluxation of MCPs, Z deformity, continual or swan leg deformity. Inflammation involving the feet, usually in the form of subluxation of the metatarsal head, hammer to rheumatoid nucleus may be in the sole of the feet, pes planus and hind foot valgus. Knees usually affected by knee effusion and bacterial cyst, glenohumeral joint arthritis with rotator cuff tendinopathy leading to severe migration of the humeral head, polyclinic difficulty in the extension or extension loss of the elbows, and temporomandibular joint may be involved, cricoarachnoid joint, which is responsible for the rotation of the vocal cords, leading to pulses of voice, sore throat, dysphagia, and inspiratory stridor. Sternoclavicular or mandibular sternal joints affection is very rare. It may be associated also with the superior migration of the rheumatoid processor C2 into the C1, leading to the compression of the stem with neurological symptoms, and anterior subluxation of C1 and C2, which is very important to be assessed in any patient who will receive general anesthesia before any surgery. Extra-articular manifestation usually present in 30 to 40% of the patient and may occur prior to the arthritis, and usually the patient at risk for developing the extra-articular manifestations are those with high titer or rheumatoid factor and asthma, HLA-DR4 positive, male smokers, and early onset disability. The main extra-articular manifestations affecting the respiratory system with the local diffusion pneumonitis, pneumonitis, the very important issue is the interstitial disease, which is responsible for the 20% of all diseases among the rheumatoid patient. Cardiovascular symptoms in the form of the pericarditis, pericardial diffusion, cardiomyopathy. Vasculitis in the form of mononucleosis multiplex, cutaneous ulceration, digital gangrene, visceral infarction, CNS involvement in the form of the peripheral neuropathy, cold compression from the mid-cyclical spinal stabilization, or intrahepatic neuropathy as metatarsal neuropathy or carpal tunnel syndrome. LI is very important because it may be affected with the keratoconjunctivitis, episcleritis, or scleritis, which may lead to scleromalacia perfluence, which is a very dangerous and very bad symptom among the rheumatoid patient. And the most important issue, which is fatigue, which is usually least assessed by us for our patient, as well as osteoporosis, amyloidosis, and malignancy, especially in the lungs and hematological malignancies. The classification criteria is primarily developed for clinical research, as all we know, and not for the diagnosis of the individual patients. However, the old criteria of the American College of Logic in 1987, it is usually used to classify the established rheumatoid arthritis because this criteria includes findings more consistent with a long-standing disease, such as radiographic damage routines. So it lacks sensitivity for detection of early rheumatoid arthritis. Even this graph, this is the important, this shows the importance of early detection of rheumatoid arthritis. Patients treated before 12 weeks is associated with a significant less joint destruction and a higher chance of achieving remission. So, the most common or the most recent in 2010 ACR unit classification criteria done by the Daniel Aritana and his colleagues, the famous rheumatologist all over the world, which was this one called Emily and Nibel, classifies this patient for early detection of rheumatoid arthritis. It shows an excellent sensitivity, 97%, in identifying patient at an early stage of RA for early treatment and management. Coming to the guidelines for the management of rheumatoid arthritis. This guideline is responsible for the 2022 update. This is not the most recent, but I prefer this one. It usually passes in three phases. The phase one, after the clinical diagnosis of rheumatoid arthritis, with no contraindication to methotrexate, we should start methotrexate as a first-line therapy with short-term glucocorticoids. Or if the patient has a contraindication to methotrexate, we can start by the flavonoid or sulfasalazine in combination with glucocorticoids. If the patient improved at 3 months by 50% improvement in the assessment and achieved the target, which is the disease remission or at least low disease activity by 6 months, you can continue on the same medications with the dose reduction in sustained remission. If there is no response, we can pass to the phase 2. If we have a phase 2 with poor prognostic factors are absent, we can change to or add a second conventional sensitivity marker to what the patient had. If the patient has a prognostic factors in the form of elevated titer of rheumatoid factor and acne, high disease activity, early joint damage, failure of non-conventional sensitivity marker, we can add a biologic demand, and we can consider the use of JAK inhibitor only after risk assessment. If the patient improved at 3 months by 50% and achieved the target at 6 months, we can continue with the dose reduction or interval increase in a sustained remission. If there is no response, we can pass to the phase 3. Phase 3 depends on on the changing of the biologic demand of OJAK inhibitor to meet the patient requirements. If the patient improved also by 3 months and achieved the target at 6 months, we can continue with the dose reduction and the interval increase. أيهما أقرب أو أيهما يناسب medication اللي أنا بستخدمها in a sustained remission. If no response, we can change again. What we have the biologic demands, the TNF inhibitors, the first generation including the infliximab and the ehtamatat, and the second generation including the remaining 3 anti-TNF, which is adalimumab, satralizumab, and nivolumab. The second generation are fully humanized antibodies with lower immunogenicity, with longer half-life and higher specificity. The non-TNF biologic inhibitors, including the rituximab, anti-B-cell, anakinra, satralizumab, which is interleukin-6 inhibitor, and serplulimab. The target-specific molecules we have only 3: paracetamib, tofacitinib, or abatacetinib. What about the glutamate in particular? Glutamate is a fully humanized IgG1 anti-TNF alpha with a lower immunogenicity and longer half-life and higher specificity. It is indicated in the treatment of adults with rheumatoid arthritis, psoriatic arthritis, axial SpA, including ankylosing spondylitis and non-radiographic axial SpA, and ulcerative colitis, as well as it is indicated also in the management of a children with polyarticular GIA with at least 40 kilograms body weight. According to the 2023 British Society of Rheumatology guidelines on prescribing drugs in pregnancy and breastfeeding, glutamate is unlikely to be harmful in the first trimester and may be continued safely throughout the pregnancy if needed to control the active or severe maternal disease. Glutamate shows an active placental transfer after the week 20, which affects the infant vaccination plans only and not the teratogenicity. So consider stopping glutamate after week 20 if the disease allows. If not allowed, we can continue it safely all through the pregnancy in the 3 trimesters. Infant vaccination plans. The live vaccines as rotavirus and BCG must be avoided in the first 6 months if the infant is exposed in the late pregnancy. During breastfeeding, glutamate levels in breast milk are very low and the oral absorption by the infant is minimal. So the British Society of Rheumatology guidelines does not forbid glutamate during the breastfeeding. And this is the published article by British Society of Rheumatology in 2022, including the guidelines on prescribing drugs in pregnancy and breastfeeding. And this table mentioned that all the TNF are safe during the preconception period, in the first trimester, second trimester, third trimester, breastfeeding, and even in the maternal exposure. Coming into the very important 3 registrational trials in rheumatoid arthritis to be approving the glutamate for the management of adult with rheumatoid arthritis. We have 3 trials that go forward, go before, and go after. And then we start with the go forward first. It usually, this study, involving patients with an active rheumatoid arthritis despite methotrexate therapy and the TNF inhibitor naive. It includes 444 patients distributed through the 4 arms. The first arm is the placebo methotrexate, the second arm is glutamate 100 mg with placebo, and the third arm is the glutamate 50 mg with methotrexate, and the last one is the glutamate 100 mg with methotrexate. The primary endpoint is the ACR20 and the change from the baseline in the health assessment questionnaire disability index, with a long-term extension to the week 256. Go forward showed that 55% of the patients achieving the primary endpoint, achieving the ACR20 response at a week 40, and about 35% achieving the ACR50, and 13.5% achieving the ACR70. Also, there is an improvement in the disability index by the week 24. So, the primary endpoints of this study in a format is achieved. The second endpoint is that patient achieving the ACR 20 and 50 by the end of the first year is about 64% and 44%. And those achieving the ACR 20 and 50 respondent by the end of the fifth year is about 70 and 50% respectively. Also, the mean improvement in the disability index from the baseline at 5 years is achieved. Also, there is a clinical remission by the week 14 and sustained disease activities through the 5 years in those with an established rheumatoid arthritis. By week 14, 27% of the patient reach the clinical remission. And by week 256, about 43% achieve the clinical remission. Leukomet also inhibits the radiographic condition in the long-term treatment. From the week 24 to the week 156, there is a significant inhibition or at least decreasing the radiographic progression in such patients with an established rheumatoid. Also, there is a significant improvement in the physical function, general health, and fatigue, assisted by the disease, by the HAQ disability index, the shortfall 36 arm of the physical component summary, and the functional assessment of confidence. All these assessment tools are achieved by the week 52. From the start at week 52. Also, there is a sustained quality of life outcomes in the established rheumatoid arthritis, the physical function as well as the short arm, 36 short arm of the physical and the mental component summary also improved by through the 5 years. Coming into the next study, which is the GO-B4, where the patients are intended those with an active rheumatoid arthritis who are methotrexate naive. It included 637 patients with rheumatoid arthritis distributed through the 4 arms. The first arm is the placebo with methotrexate, the second arm was the glimumab 100 milligram placebo, or the third one is the glimumab 50 milligrams and methotrexate, and the last one is the glimumab 100 milligrams of methotrexate. The primary endpoint here is the ACR 50 and not ACR 20 at the week 24, and the level of a change from the baseline and the modified chart score radiographic progression by the week 52. Also, there is a longer-term extension to the week 256, about 5 years. The efficacy in the methotrexate naive rheumatoid arthritis patient showed about 40.3% of patients achieving the ACR 50 as early as the week 24, as well as the modified chart score is improving by week 52. These are the primary endpoints achieved in this study. Also, there is a sustained efficacy outcomes in methotrexate naive patients. ACR 20 and 50 responders by the 5 years is about 72 and 55% respectively. Also, there is a many changes of the radiographic outcomes are also much less with these patients. So, patients remained in the trial through the 5 years and they had sustained improvement in the clinical and radiographic outcomes with a long-term safety results. The last one is the go after study, which included patients with an active rheumatoid arthritis and previously treated with 1 or more TNF. These patients are difficult to treat because already they took previously the conventional synthetic remark and experiencing 1 or more TNF with no response. The primary endpoint in this patient is the ACR 20 by week 14. Here we can show that 35% of our patients reach the ACR 20 by week 14. 16 patients reaching the ACR 50 and 10% reaching the ACR 70 by week 14. Also, the ACR 20 and the 50 responders at 1 year reach about 40% and 18.4% respectively. Also, the HAQ 13.4% to those treated with glutamate 15 milligrams. Also, 38% of our patients reaching the ACR 20 by the end of the 5 years, and 25% reaching the ACR 50 by the 5 years. There is also clinical remission in these refractory patients. About 8% and 10% achieving remission by the week 14 and 12% by week 256. And more than 20% achieve low disease activity. From the real world data from the German, Finland, Japan, and the Canada, we can illustrate that. There is a high retention rate as a first-line therapy at 5 years. In total, 2,228 adults, participants in the RA, PSA, or AS studies. Glutamate retention rates at year 5 were consistently high when used as a first-line therapy. About 70% of the patient is adherent to the medication. In a German study done in 2018, showed is an improvement in disease activity through the 2 years of continuous treatment with glutamate. And after 3 months in this chart, 33.7% of the patients were in remission and 44.6% after 24 months. In a the study published in 2017, there is a clinical response and remission among the TNF inhibitors in their practice. In this Finland study, we can show that the glutamate was associated with the largest proportion of patients, about 64% in remission at 6 months, if it is taken as a first-line therapy. Also, there is a drug survival rate after 6 years. Glutamate, in comparison to other TNF, anti-TNF, and abatacept, showed that 61.5% has a drug survival rate after 6 years. And this can be explained due to the immunogenicity differences between these medications. Also, glutamate had a low discontinuation rate in 2 years in a Japanese study published in 2019. It is about 7.2% discontinuation due to adverse effect and 20.7% due to insufficient efficacy, which is much lower than the other compared medications used. In the same study, immunogenicity of all TNF showed that patients with taking glutamate showing a 3.8% of antibodies against this medication, which is much lower than those for the infliximab or adalimumab. It has a low infection rate, as mentioned in a study done in Canada population in 2023. Also, the patient adherence. 80-70% of the patients treated with glutamate were adherent to the treatment. As all we know, 50% of all patients in the world with a chronic medical condition, with any chronic medical condition, 50% don't adhere to their medications. And finally, to conclude, the glutamate trials collectively highlight glutamate's consistent clinical values across the full spectrum of rheumatoid arthritis therapy, from methotrexate evaluation to those with inadequate response to prior methotrexate or biologics, confirming its reliability as a long-term treatment option. Together, these trials demonstrate that glutamate delivers a durable improvement in disease activity, function, quality of life, regardless of treatment history or disease stage. By showing the benefits in methotrexate-naive, methotrexate incomplete responders, and biologic experienced patients, these studies position glutamate as a treatment that adapted to patients rather than requiring patients to adapt to the drug. And finally, these trials show the consistent ACR responses and the reduction in radiographic progression reflect the glutamate's capacity not only to control the symptoms but also to provide long-term trajectory arthritis with no increased incidence of serious adverse effects. And finally, I would like to thank you.
Thank you, Dr.
I would like to visit as soon as possible our great museum just launched in the first of this month. Thank you for
Thank you, Dr. Mohamed.